Hi, this is Eric Cressey, and today I wanted to talk to you about ulnar nerve hypermobility. I actually posted a video late last week where I demonstrated an ulnar nerve that was snapping back and forth over the medial epicondyle in a thrower I saw. We got a lot of questions as follow-ups on how to address this, what do you do if you have this, is this a big problem? First thing I'll tell you is remember that this is an incidental finding for between 10 and 33% of the population, depending on the study you look at. I actually have myself, my elbow pops quite a bit on both sides, so it's just an incidental finding for some people. For some people, it's a little bit more concerning. So first, let's take a look at that video and then we'll go from there. What we need to consider about the ulnar nerve is the functional anatomy that's involved. And the ulnar nerve starts on C5 to T1, the brachial plexus, and then runs out, and it can be impinged by a number of different structures as it works its way all the way down to your fingertips. What we know about ulnar nerve symptoms is that they often come about when that nerve is compressed or it's overstretched. So we want to make sure that we clear all those different places where it can get caught. It can get snagged on the scalenes as it comes off the neck. It can be snagged between the first rib and the collarbone. And then it can be snagged at the front of the coracoid process where pec minor, coracobrachialis, and the short head of your biceps attached. It can be irritated in the front of the shoulder if there isn't good rotator cuff control and you glide forward, particularly during external rotation. If you have a really stiff, nasty subscapularis, that can mechanically impinge on it. Not only that, as it runs a little bit more medial, the triceps can get gross and kind of mechanically impinge there. It goes into the cubital tunnel and we have concerns there, and then it can get flopping back and forth over the medial epicondyle. So we want to make sure that before it works its way down there and into the flexor carpi ulnaris and then down into the fingertips, that we've cleared all these different areas. And that's where great manual therapy can make such a difference. First off, we treat the scalenes and get things moving there. Second, we want to be cognizant of, do people have a really depressed clavicle? If someone's in a lot of scapular depression, they have a very lat dominant extended presentation, that clavicle can sit up really low. Subclavius is a big player there because it effectively links the ribs to the clavicle, so we want to treat there. As you run more laterally, if someone is more anteriorly tilted, we want to find some posterior tilt, find some tissue extensibility in the front so that those nerves can glide a little bit more freely. And then when we get to the shoulder, especially in throwing athletes, when we have a lot of layback taking place, we need a good rotator cuff to make sure that the ball is centered in the socket. We're not gliding forward and irritating it. We need to treat long head of the triceps, the medial triceps. We also need to get in and work on flexor carpi ulnaris below where the ulnar nerve actually goes into so that things are freely gliding. And only then can you really critically evaluate whether this is a nerve that's going to be a problem for you. With that said, ulnar nerve transposition is a surgery that just takes the nerve over to the medial aspect of the arm. So basically it doesn't allow it to pop in and out of that groove as you go through flexion extension. Usually a pretty quick return to function on that one. Additionally, you always want to make sure you rule out more central causes, whether it's thoracic outlet or something at the scapula. And then last but not least, personally, one thing I've done well to take care of this when it does get a little bit cranky on me is just an elbow sleeve. For some reason it tends to help keep that nerve in place. It's not an aggressive compression, it's a really light one, almost like a sock that has the end cut off, or a sleeve that you can get for use in the baseball community. That tends to hold things in place. But don't think anything's wrong with you. If your nerve does snap, it might make some noise or even just that feeling of moving around, but it doesn't mean it's pathological. Only if symptoms arrive, you need to get this checked out a little bit further with a qualified rehab professional or sports medicine physician.